So my name's Dave Martens. I'm the clinical manager of cardiac rehab at Doylestown Health. Thank you so much for coming. So Dr. Comenzo said, Dave, I think it would be time to talk about your new program. So in February of 2018, Medicare approved that we could exercise patients with peripheral artery disease or peripheral vascular disease. So we were one of the first hospitals in this area that got our program up and running. So instead of using the term angina for a heart patient, we use a different term for patients that have a blood vessel problem that feeds either their glutes, their hamstrings, or their calves. So they're going to have, this type of patient is going to have a discomfort or a pain. We call this claudication. So they're limited with how far they can walk, they're limited with how fast they can walk. And then as their symptoms get worse, they talk to their physician and then they get referred back. So you need a physician referral to do this program. So now let's talk about risk factors that cause the disease. So it's the same players: tobacco, diabetes, high LDL, blood pressure, inactivity, being overweight. So now what I thought would be interesting is to I think we learn best with visual. So if I could have 3 volunteers, so there I have Karen and Christine, there's 2 volunteers, so we'd have another one. So yeah, I'll take a volunteer, so come on here. All right, so we're gonna have these 3 people right here. So all 3 of you right here. All right. So what's your name?
Terry.
Terry? Terry's going to be the good cholesterol. All right. Terry, you're the good guy. You're going to hold Karen's hand, and Christine, you're going to hold Christine's hand. All right?
Hey,
all right.
Terry never lets go of the Starbucks.
All right. So the good cholesterol is called what? HDL. H for happy, H for healthy. All right? And the bad cholesterol is called what? L for lethal or L for lousy. All right. So in a normal circumstance, Jerry here, the good guy, he's going to take these guys through. So go ahead and walk through. So that's the normal circumstance, okay? All right, so now go back there.
Come on, Jerry.
So that's the normal scenario. Now you can also see here that if you know, I got the arrow showing blood moving this way. So this is the opening. You see, wow, not a very good opening, and that's because the bad cholesterol got in here, right? So now there's less room. So now let's talk about, what does smoking do? It eliminates, it reduces the amount of good cholesterol. So Jerry, I'm sorry, but now you're not going to be part of this one. So now Karen and Christine, come in here. And so now you stay right here. Now there's more opportunity for cells to grab and bring in. I got you, Christine. And so now when bad cholesterol gets in that wall, what happens? So a lot more cells are going to come in there. It's kind of like a splinter, throb. It's going to get bigger and bigger and bigger, become unstable, and then the disease is going to get a lot worse, okay? So tobacco, it's a horrible thing to use because it reduces your HDL. You don't have Jerry anymore helping you out, and now cholesterol has more opportunity to collect. So now let's come back in here, come back at the start. And now can I have 2 more volunteers? 2 more, all right, come on. All right, 1 more volunteer. All right, all right. So now you guys, you're not like Jerry, you're bad cholesterol. All right, so come on back here.
Yeah.
All right. All right. So now in this scenario, we have a problem of a person that has genetics. They have too much bad cholesterol. And so what do we do for people with too much bad cholesterol? What's the doc do? See, medication, that's correct. Usually we'll try statins to reduce it. But in this scenario, they weren't on it, and so now Jerry can clear the first, right? So again, Jerry, take them through. But now you guys come on with. And now there's more opportunity for cells to grab and bring into the wall bad cholesterol. And so what do we need? What do we need to get that bad cholesterol number down to? No, what's the number?
120.
All right, so a lot of different numbers, right? So the latest research indicates we need to get that bad cholesterol under 70. Lower the better, under 70. All right, so when someone tells you, you had this test done and you're okay, don't stop at that. Ask what my number was, okay? Ask for your number. All right, so I'll just now, go over some other things. So thank you very much. So another scenario is diabetes. So when you have diabetes, the blood's thicker. It's kind of like syrup, right? It's thicker. And again, there's going to be more cellular activity to grab and pull bad cholesterol in. Blood pressure. What's blood pressure? It's the force of the blood, right? It's how much force the blood's giving against the wall. So if there's too much force, we're going to damage this, and that's going to cause the disease to progress. So what should your blood pressure be? What's the number?
120.
Yeah, less than 120, less than 80. If you're a heart patient, what's the number? Less than 130 and less than 80, okay? So those are the blood pressure numbers. So if we have good blood pressure control, we're going to dramatically help improve things. So again, if I'm overweight, there's going to be more cellular activity, grab and pull. So that's the pre-cardiac rehab, okay? So now you see this big blockage here. Now, if we look at this, number 2, one of the things we see is, hey, it's a little bit bigger in here. And the bigger the opening is, then the more blood can move through. Blood flow resistance is related to the opening of this to the 4th power. In layman's terms, any small little change that we can give that patient, it's going to dramatically improve blood flow through the vessel. So the other thing that you can see in this diagram is we have a new opening, a new vessel. What's that called? Collateral circulation. So exercise, you can grow a vessel over this area that might not have good blood flow, or maybe a blood vessel actually attaches to it. So there's a lot of different things that can happen, but you're going to improve blood flow if you do what? So we're gonna make this bigger, we're gonna shrink this plaque down if we do what? What do we need to do? Exercise, and we got to reduce all those risk factors. We got to get our blood pressure below 130 over 80. We got to get our if we are diabetic, we got to get our A1C below what? 7. Below 7. So we got to get, if we have a cholesterol issue, we have to get it below 70. Okay? So now our program. Our program to help you get this result is completely different than a cardiac patient. So in cardiac patients, we put them on lots of different pieces of equipment. Not true for this program. We're going to use the treadmill, and the reason for it is you get better outcomes with the treadmill with this type of issue with circulation to the legs being a problem. So the other difference is, rather than a long duration, we're only going to use a short one, like 8 minutes. That's it. Another difference is we would never exercise a heart patient with chest pain, but guess what we do with this patient population? We exercise them with mild to moderate leg pain. So we actually find a speed and grade that causes symptoms, that causes pain, discomfort to their legs. As they get better, what do you think, and their symptoms go down, what do you think we do? We speed it up. We want to keep those symptoms going on. Those symptoms do what? Those symptoms cause their vessels to react and get bigger, to grow new support. So that's why we do this special protocol of short duration. Why do you think it's short? Why not 20 minutes with leg pain? because we don't want to damage the leg muscles. Right, it would hurt too, it would be too painful, but also we could actually kill the leg muscle cells. So we don't want that to happen. So we give them breaks, which that's very different. Patient's done, they clean the equipment off, they go to their next piece. Not true with this type of patient. They need to rest until their pain completely goes away. Then we get them back on the treadmill. So while they're waiting, we'll keep them busy. Could be some stretching, could be some upper body activity, and then we get them back on the treadmill. At the end of 1 month, our goal is to have them over 30 minutes on the treadmill. At the end of 12 weeks, we want them over 50 minutes. So they'll do 4 8-minute treadmills by 4 months, and then hopefully by the end of the program, we might progress some of those 8 minutes to 10 minutes. Okay? So and then they're done in 12 weeks. Now, I say they're done, but they're really not done. The next thing that they have to do, so with this protocol, you really got to be in it for the long run. And research shows that they need to do this for 9 months. So the Health and Wellness Center, we have another cardiac rehab program, and they'll do that program for 6 months. They'll be in that program for 6 months. And that's what it takes. To get to this result, we need at least 9 months of great effort on reducing the risk factors and complying both with 3 times a week in our program and 2 times a week with home exercise. And that's our program. Any questions?
We're changing the diet in that process too?
Diet's huge. So let's talk about a bad diet, a lot of processed food. So now we have that LDL, and when you eat processed food, we're going to oxidize. The body will react to that processed food. It'll be oxidized, and a cell will grab it and bring it in. So when your diet is not healthy, when you eat a lot of man-made food, you're going to have more activity of pulling your bad cholesterol into the wall of the vessel. Excellent question.
Because of more inflammation is what I'm thinking.
Exactly. Exactly. So as that LDL, accumulates, it's going to trigger a lot more inflammation. Yes.
The question about the number 70, is that total cholesterol or is that?
No. That's your LDL, low density lipoprotein. Yes.
How do you identify patients that qualify for this?
So all you need is if you have symptoms when you walk of discomfort, then you should talk to your physician. And then they'll do some tests, like they'll look at your blood pressure at your arm versus your ankle. And they'll see a difference. And if the difference is enough, you would qualify. Any other questions?
I've heard from a kind that butter is better for you than margarine, or you don't know which is true.
Yeah, there's some I think so long as you're not using a lot of butter, if it's a small amount, and most importantly, your LDL is in the right range, you're okay. But if my LDL is not in the right range, I'm changing everything, okay, until I get my LDL in range. So I think that's the most important thing. Any other questions? Yeah.
Dave, is there a difference in the LDL guidelines for people who have not had heart problems?
Yes, there is a different goal. So if you do not have vascular disease or coronary artery disease, the goal is to be 100 or less, not 70, not under 70. Any other questions? Okay.